It's a pleasure, everybody. Good morning, good afternoon, or good evening, wherever you may be watching this webinar. I want to set the stage with the presentation. Just first, a couple of housekeeping items, just some of the disclosures that just for the sake of transparency, we can present those. With regards to the series itself, the disclaimer was already brought forth. This is for educational purposes only, and the opinions that are presented here are those not representative of GE itself, and that's a shared collective between Dr. Cecconi and myself. You've already heard about Dr. Cecconi and myself, but let's go into the objectives. So this is going to be a high-level overview of the consideration of redesigning the hospital of the future with a lens towards what's called adaptable acuity models. Before we get into that, my portion of the conversation will really talk about the foundational issues. How did we get here, and why do we need to look at transforming the healthcare delivery models that I've been part of since the early 1990s? Why is there a need for change? Typically, that means that there's a criticality that's upon us, and I will go into the details of several of these stressors that are converging into this quote-unquote perfect storm. So on that note, let me go into my component, focusing on the demographic shifts. So the first element here is, for those that are not aware, the population pyramids, which is what you're seeing here. These are graphics that are coming from Eurostat. The overlay is quite striking. That is the red. That's showing that that our population, and this is Europe, but it's representative of the United States as well, is that our population is aging. Specifically, if you look at those that are older than 85, between 2019 and 2050, you're going to see almost a doubling from 12.5 million to just under 27 million 85-year-olds in the European Union. And it is known that there's a direct correlation between increased age and increased comorbidities. So clearly what we're seeing is that there is a population shift where the patients are getting older, and now they're also going to be having more comorbidities. And care of patients in general is not cheap. If you look at from the United States standpoint, from Centers for Medicare and Medicaid Services, CMS, 1/3 of hospital expenditures in the United States come from the hospital itself. So that's ED, ICU, and the transition out from there. Me being an emergency physician, I could see, I saw this firsthand, where quite a bit of the inflow of hospital care came through the emergency department, noteworthy within the United States. What's interesting is that over the past 10 to 15 years, demand for emergency medical services in the United States has increased by a decent amount, just over 18%. And associated with that, you can see that the complexity of the patients and/or the criticality of the patients is increasing, because admissions have also increased by just over 8%. Similarly, in the United Kingdom, according to the NHS, ED admissions have also increased, not as noteworthy as that in the United States, but still over 3%. Complexity is increasing, age is increasing. Those comorbid conditions are stacking up, as we say. And the graphic to the right just tries to help paint the picture. Back in 2006, not that long ago, the number of patients that were admitted with 5 or more comorbid conditions was 1 in 10. That's changed. In 2015 to 2016, that has increased to 1 in 3. So it's quite striking that there is a demographic shift that's occurring of patients coming into the hospital. Tying that now into something else that is a concern is from the demographics of the hospital care environment. And this is, the issue of critical care specially trained personnel is not new. 2004, this is a blurb that I extracted here, and I'll quote it. It was from critical care societies. It's a federal call to action, so that means that this was so noteworthy that they wanted to go and let the federal government identify this as a crisis. This is 2004, and they say compelling evidence exists that the demand for critical care services has already begun to exceed the supply of physicians trained in critical care. The increased demand in critical care services is caused by a significant growth in the elderly population. What have I just been talking about in the past 5 minutes? We're seeing increase in comorbid conditions going from 1 in 10 to 1 in 3, and that's now. They were talking about it when it was at 1 in 10 or less than that. So clearly we are having a convergence of patient comorbidity and a lack, especially trained physicians and clinicians in the critical care environment. And this is a Halpern extract, a graphic that is basically showing that there's a gap. This gap is starting to grow where the inflow of critical care trained physicians, and this also applies to non-physicians that also work in the critical care environment, is not being met by the demand, because there's a fair amount of attrition that is occurring on the back end, whether the physicians or nurses stay in administration and leave clinical care, they go into consulting, or they just simply retire. So clearly there's an issue here now with regards to staffing, and the staffing is becoming more noteworthy. If we see during the pandemic in contrast to pre-pandemic, just the critical care staffing ratios increased, going from 2 to 1 to 2.4 to 1. So a noteworthy increase where you have more patients that are being managed by the same critical care team, but now these patients also, based on what I was saying a few minutes ago, the age is going up, the comorbidities are going up. So the ratios are causing a strain as well with regards to staffing issues. And like I said at the beginning when I'm teeing this off, there's a convergence. There's a convergence of patient demographics and hospital staff demographics that are creating a perfect storm, and it manifests during the global pandemic. So the next phase of this is what happens to a hospital during a crisis such as what we experienced within the past several years with regards to the COVID-19 pandemic. And here is an overview of kind of the various stressors that occurred. I'm not going to recite them one by one, but you have to understand the hospital up until the pandemic occurred and onwards, they still had their base case of patients to manage. COPD exacerbations, congestive heart failure, myocardial infarctions, strokes, knee replacements, cancer care. Those remained, right? That demand, that basal demand remained. And now you have this onslaught of infected or potentially infected, but not at the threshold of requiring higher intensities of care for COVID. How do you manage those two populations while being able to allocate resources accordingly? So it really did put a lot of stress on the healthcare environment to be able to manage these different patient populations. But it goes beyond that. We're talking about staffing. So staffing was another element that clearly we can talk about with regards to burnout, isolation, the fear of getting infected, and the inability to communicate because you're in PPE all day. But then look at just at a hospital standpoint, resources. Did you have enough mechanical ventilators? Clearly, in the United States, we did not. There was a federal action that got entities like General Motors and Ford to start making mechanical ventilators. Personal protective equipment was being stripped out quickly. I supported companies that were repurposing N95 masks for reuse. So clearly, there was other stressors outside of just the hospital environment, the care delivery, as well as the staffing, but there's all these other elements that help to create a hospital that works. And then lastly, you work in an environment where the hospital is fixed, right? You have hospital beds. How do you go and deal with surge capacity? There's only limited areas where surge capacity has already been created, and what you're starting to see is that there's elements or learnings from COVID that identified how to be able to better handle surge capacity and be able to flex care to patients within a fixed environment. And let's not forget, and one of the important elements is stress. The stress on the patients, the stress on the families, the well-being, the mental well-being of the employees. All of that also resulted in suboptimal environments for the patient, as well as burnout for the hospital staff. So, putting simple numbers, if you're looking at bed capacity, ICU bed capacity pre and during the pandemic, it went up by quite a bit, approximately 75%. So we went from just under 5,000 to just over 7,600. That's US-based statistics. What's interesting is that there was a reliance on hybrid model care delivery, where nearly 2/3 of the hospitals had to rely on non-ICU locations and also non-ICU nurses to be able to provide that delivery. So hybrid models, quote unquote, hybrid models had to be implemented out of necessity, which raises now the question and the entree for the conversation of other models of care delivery, one of which is adaptable acuity. How do you better manage a patient population with these constraints and being able to tailor resources to optimize care delivery to the patient and being focused on the well-being of the care of the practitioners. On that note, I'll take my pause. I'm going to hand it over to Professor Cecconi, who will carry on the discussion of adaptable acuity, as well as how to envision redesigning the hospital of the future.
Thank you, Bob, and hello, everyone, and great to be here. I would like to thank G for organizing this. This is a very important topic. It is always being an important topic to see how we can adapt to different situations and different intensity of situations in intensive care. I've been working in intensive care for more than 20 years. And as if you also work in emergency, in acute medicine, in intensive care, you know that we move from situation where we can discuss together at the bedside what's happening and have time to think about the physiology, to do rounds and stuff. But we also know that it could be moments where we may have one crisis or two crises at the same time. So acuity is a concept also for ICU beds. And we know that ICU beds in terms of proportion for beds in hospital now are increasing more and more. Probably what we do need is the ability to have patients that can be taken care into an intense environment if needed, but also to be scaling up and scaling down. So this is one of the concepts of what we mean with adaptable acuity. And as Bob was already saying, we had a big stress period, all of us, with the COVID pandemic. And I think the COVID pandemic has been a catalyzer to understand probably how we need to get better prepared for the future. This is a piece that we wrote with some colleagues about what we've done well and what we could have done, or maybe what we should do better the next time. So we have tried probably at the best to use other areas of the hospital to expand our ICU capacity. And this was something that I was particularly involved at the very beginning. You may remember Lombardy, which is where I work, was particularly hit. And before the pandemic, everyone was getting ready for possible flu outbreaks, bad flu season. We were thinking about ECMO patients. No one would have ever thought that actually we would run out of normal ICU capacity and how we would have increased that capacity. So this has prompted also some reflections on how we can, during normal times, have resources that should not be wasted, but that could be used really to accommodate different levels of intensity for our patients and also different kinds of intensity for our hospital. It's common knowledge to everyone that works in large hospitals that during the winter season with surgery ongoing and respiratory disease, sometimes we're a bit more stretched. This is not the case maybe later on during the spring and summer, but still we have to find ways to optimize the flow of patients and the resources that we use. And so if we think where we could do maybe better next time, I think it comes to how we can prepare really our systems to be able to cope with crisis. And crisis doesn't necessarily mean the next pandemic. Crisis could just be how do I accommodate the next increase that is happening next week because I got some referrals for high-risk surgery, and at the same time I got few more patients that require mechanical ventilation. So we need to train, I think, normally in these concepts. So probably we need to think how we can adapt our system to small crises and to larger crises. Of course, the digital transformation that has occurred in some parts of the world faster than in others can help us in this case. If you think about even telemedicine and how we can bring knowledge and trying to use at best the knowledge of the limited number of clinicians that we will have in proportion to the number of patients that require our expertise, it is also something that we can do. But of course, we should also not forget, and I will come back to this soon, we should not forget about the staff. One of my mantras during the pandemic when I was speaking with the institutions to ask for some more support was the fact that we should not focus just on ventilators and drugs, but really we should focus also on people. So to understand how we can protect our healthcare workers, how we create good working conditions even during times of crisis, and so how we can surge and still find ways that are really suitable for our healthcare workers to deliver best care to patients and families. And really, this is one probably of the major issues that we have in intensive care. With this increase in demand that Bob was explained before and that we are seeing continuously in front of our eyes, and it's just going to get worse, unfortunately, because thanks to the successes of medicine itself, populations are getting older. We see patients with comorbidities that we would have not been able to see and to treat 20, 30 years ago. So our own success is bringing new issues and new challenges that we have to face. And so to believe that we can just carry on with the previous model probably is not going to work. There is an imbalance of demand and resources. So we need to be probably more disruptive in the way we think about acute care in the future. With the challenges and the responsibilities, also thinking how can we implement all these new changes in concepts like sustainability, also in terms of green ICUs and so on, with younger generations that are demanding different ways of work-life balance. I think we should not fight that. I think we should embrace them, work with them to understand how we can create environment to work in intensive care so that intensive care units can stay or can become even more, if we've lost that appeal a bit, places where the younger generation would like to come and work. I still think it's an exciting job to take care of patients in this way, but we need to adapt to new situations. And probably a smarter way or a better way, a more efficient way to utilize our bed is going to be even more important. Again, with technology, with understanding how we can optimize processes and concepts like value-based healthcare. Maybe they were a philosophy embraced only by some hospitals in the past. I suspect they will become a necessity. Again, with more demand, less resources, we need to understand what leads to a better outcome, how to optimize processes, how to reduce waste, how to think how healthcare workers can work at best. And really, we should not forget the things, because as Bob was already saying before, if we forget this, we can make the problem even worse. With the European Society of Intensive Care Medicine and Elias Zule, we did this study during the pandemic, and we found that basically up to 50% of healthcare workers working in intensive care, they had experience or had some symptoms related to burnout. And I'm sure that what I'm saying is not new to anyone listening today. You know that we've lost, and we've seen many nurses especially, but also colleagues going away from intensive care, maybe moving to other industry. Maybe this is a good thing sometimes if they wanted to change career. But if they left because the conditions were not appropriate anymore, this is a reflection that we need to have, and we need to have urgently, and to see really how we can really think about different models of working. I speak a lot about new technologies. I give lectures about how artificial intelligence, for instance, data visualizations, even robotics can help in this sense. And it's my vision, actually, that we should work with companies to try to get technology that makes our work smarter, and in a way that gives us even more time to think about the patient and doctor relationship, physicians, they can spend more time maybe with families and so on. So how can we actually do that? Well, I think considering the massive amount of data and information that we get continuously, really we need to think how we can process all this information, how we can get all this information in the right way so that our job is facilitated by this. And you know that the amount of data that we collect and we produce in intensive care is enormous. We almost have a paradox now that we have so much information that actually we lose information. We have so much data that it becomes difficult sometimes to spot the difference between noise, background noise into a signal and the real signal. So artificial intelligence, data visualization tool, electronic records are going to be very, very important to produce dashboards that can help us to visualize the trend that is really important there. But at the same time, we may struggle to have an intensive care specialist available for every bed, for every physical bed that we have at any one time. So what are the solutions for that, and how can technology help? Well, I would say that probably the US in this sense has been a pioneer and has been showing to the other parts of the world how, for instance, different models of telemedicine can work. When I consider telemedicine, I use a very large description, in the sense that to me telemedicine could be a system like this one in this picture, where you have a room, a control room, where you can see patients from different areas of the hospital, maybe from different hospitals, and you can bring your expertise. But at the same time, you can imagine telemedicine in a more simple way, where a clinician can offer that support, maybe just to a patient in another ward without having to walk there, as long as you can relate to another healthcare workers. You may think of this unnecessary, but if you think about the amount of time that our nurses and our doctors, sometimes they spend just walking around the hospital, losing valuable time to interact with patients, to interact between them, to interact with us, it's probably something that can help, especially in a context of shortages. These are also some implications in terms of work-life balance. You know that there are some experiences, for instance, in which to try to find more doctors covering night shifts that not a lot of people want to do, you can actually employ physicians and clinicians from other parts of the world that have the skills and know your system, that they can provide a nighttime cover while it's daytime for them. Maybe this does not apply and may not be feasible everywhere in the world, but it's certainly models that I think we should look at and have an open mind about seeing how we can optimize resources, get more expertise, and at the same time maintain for as much as possible work-life balance. Robotics are certainly going to come to our hospitals more and more. Again, this is a necessity, it's not even an option anymore, in the sense that for the same problems, more patients, sicker patients, in proportion less healthcare workers, we need to try to automate at least some of the tasks for the healthcare workers. Maybe the next robots that we will see in the next years are not going to be like in this one, where there is not even a nurse at the bedside. I don't think that's something feasible and realistic in the next couple of years, but we already start to see robots that are helping our pharmacies delivering drugs, preparing drugs, bringing that to the bedside. Anything that is increasing the time that clinicians, nurses can spend with patients, bringing valuable clinical time, everything I think should be welcome. And also the technology will allow us maybe to see things that our eye cannot even see. This is a very interesting study. You may have seen it. It was published a few years ago now. But basically, a deep learning algorithm was able, through examining the eye of patients to identify the gender of the patient. This is something that our human eye and our expertise, even the most experienced ophthalmologists, cannot do. So we are opening new frontiers here with this. And again, I don't think we should be scared of these revolutions as long as we are leading this revolution, as long as we are driving this revolution. The ability to see something that maybe we are not able to see normally, and to help us to spot, for instance, deteriorations that are not easy to spot clinically, I think this is something that we should really welcome. So early warning scores, sensors and wearables now, and these massive networks of physiological data that we can have in different parts of the hospital are going to be crucial. And even when we talk about adaptable acuity, I think this is going to be crucial, because when we speak about these concepts, I do believe that we will have hospital beds that will be able to scale up monitoring and maybe to a certain degree levels of organ support as much as possible. But there is a limit maybe where we have to transfer this patient and cohort those patients in very high intensity areas, so in the level 3 intensive care units and so on, where we really want to treat those patients and to maximize the expertise and the knowledge that is there. So for that, we really have to have integrated approaches and to be able to spot what's happening at the bedside. And so our outreach teams probably will have to work more. Our medical emergency teams, they will have to go and check if a patient can still be managed safely in a ward or not. And technology is really changing so fast. These are just some of the two most recent handled echocardiography devices, but it's impressive how fast things are changing now. I remember when I started to get a picture anywhere close to this, probably you had to take an echocardiography machine, which was very expensive, was taking as much space as a hospital bed, and now you can have this in the palm of your hands, even with some technology that is helping you to get the best image. So this is AI-guided basically recognition of how you can take the best images. So you're even with this help, removing probably the need for skilled people to get the image, because the machine itself will help you to get that. And then maybe you can just focus on the interpretation. When we looked at, for instance, during COVID-19, at how our hospital wards were changing in terms of acuity, we did this study, which was basically the use of heat maps. And what are heat maps? Heat maps are systems that we developed so that we can plot different signals in different wards. And we wanted to see what happened from before to after the beginning of the pandemic to the proportion of patients with deranged vital signs. Here you see for instance, respiratory rate from the ward that in the hospital was considered the one with more deranged vitals. At the time before COVID, basically 0.92% of patients normally had respiratory rates higher than 25. I think it was in this study. When COVID started, it was more than 10%, up to 10%. Why is this important? Well, imagine a system in which you want to deploy or to understand how to best utilize your human resources at any given day, and to understand which ward maybe may need some extra help and which other wards may be safer to be managed with the system that you have. So again, to have these dashboards will allow us to monitor individual patients, but at the same time to monitor how hot or how cool a patient, a hospital is, so that we can really focus on individual patients, but at the same time think about how to deploy our resources. Now, for this to become a reality, and for our hospital beds ideally to be all monitored, to be able to be monitored in an adaptable way and to go up and down, this is going to work if we work in a completely connected environment. And a completely connected environment, it means that it needs to be integrated, data needs to be open, and I really think we have to demand that interoperability becomes a standard in this sense. And if we do this, then we should not forget also about the fact that everything that we do, and again, technology can help here, is for the benefit of our patients and their families. So Telemedicine can also be a way to bring connections with a clinician, even in patients that maybe now they've been discharged and now we have follow-up, but they don't live close to the hospital. I'm putting here a picture of a music at the bedside. I think we should not forget these things. This is not high-tech, but this is certainly something that should remind us that if we go to this technological revolution to be able to take care of more patients, we should not forget this human side of things. And virtual reality can, for instance, help patients. There are experiments ongoing now. We need to see what is the best way to do it, but you can imagine that you can bring a patient that is rehabilitating even in his home environment, or you can help families of patients to understand what an intensive care is like. This is an experiment that, for instance, we did with the European Society of Intensive Care Medicine when I was president. And if we use technology properly and we have the ability to redesign our hospitals, really we should understand how we integrate all these concepts into a human way. And the idea to keep a patient as much as possible into the same room is actually, it's a very human side of healthcare. Patients and families, they don't want to be moved around the hospital too many times. Of course, they want to receive the best care. If that is necessary, they accept it and they are happy with it. But if they can, they would prefer to stay in the same place. That becomes their home for the time that they are in the hospital. Technology is very interesting. This is an example from one of the hospitals in Milan. It's a neonatal intensive care unit in a very old building in the Maggiagalli Center in Milan. I'm focusing on this to show you also how technology can help to make things more human. If you look at that ceiling that is here, and you see the sky there, the blue sky, actually this is a fake. This is a very sophisticated light that mimics the natural sunlight and the daylight. And if you look up, you believe that there is sky there, and it completely changes your mood if you are a parent or even a healthcare worker working there. The reality, above the ceiling, there are 3 or 4 floors, so you will not be able to see natural light. I do think that we need to embrace also this and to think about how to humanize old spaces, even in spaces that maybe you cannot build up from scratch. So lots of concepts here, but what is the evidence for it? Well, I think a lot is probably common sense and experiences, and the experiences of what we're seeing from COVID. This is, however, also an interesting paper that was published before COVID from the University of Wisconsin, where they use an adaptable acuity technology to see if in cardiac surgery patients, they were able to see differences in outcomes. And they saw that, for instance, they had less complication, less ICU, length of stay, even less readmissions to the intensive care. What are the reasons for it? Difficult to say. These are pre-post studies, so quality improvement. So it's always difficult to completely understand the difference between an association and a causality there. But certainly when you see quality improvement like this, probably one of the reasons could be that you're minimizing transfers. We know that transfers of patients and moving patients is associated with an increased infection risks, for instance. But again, every time you move a sick patient, there are other risks associated with it, with the transfer itself. These are just some of the reasons for it, but there could be others that we've not been able to completely study yet. I'm just going to come to the conclusion of my talk. I passed already the messages of why I do believe that we have to focus on people, but really this is key. I think it would be a mistake to believe for our hospital management that we can just buy all sorts of smart monitors and very fancy technology can scale up and scale down the monitoring without understanding who is taking care of those patients. So one of the mantras that I was saying to the European Commission when I was president of FFICM and advising them on how to get ready for the next outbreaks after the first one was that a ventilator is not an ICU bed. An ICU bed is a group of competent people working together as a team. And that's why we asked and we achieved funding actually to train people, to upskill maybe the skills of clinicians not working regularly in intensive care. If we embrace this revolution, we should not forget healthcare workers. Actually, healthcare workers should be at the center of the revolution, and we need to find ways to use technology to allow them to do the best work for patients and families. And This is my last slide. If you want to read, I was asked to write a piece on how I'm imaging intensive care in 2050. The way I wrote this was actually imagining that it's now 2050 and I'm about to retire. And my idea and my hope is that actually technology would help us to do the work better. It will augment our reality to take care and to do earlier and better diagnosis and better treatment, to deliver better treatment for our patients. But at the same time, more importantly, will give us time to spend with our patients and their families. So in a way, more technology to allow us more time to connect also at a deeper human level with our patients. Thank you very much.
Thank you both for sharing your expertise and insights. This is interesting. I have to admit I've not seen those lights before in the unit. That seems like I've definitely worked places where that would be exceptionally helpful. So lots of ways for adaptation here. We will now spend a few moments addressing some of the questions that have been submitted by the group. At this time, unfortunately, we're only able to address questions that are submitted in English. And please note that maybe not all of the questions and responses may be relevant in all settings. So with that, I'm going to go ahead and ask the first question to our presenters here. The question is, can you describe the clinical care areas or pathways where this idea of adaptable acuity may be better suited? Areas where it may be more successful than other areas where it may be more of a challenge. So anywhere stand out to you?
Yeah, maybe I can start off, and then I'll hand it over to Professor Cecconi. You know, as shown in the slides, University of Wisconsin has shown evidence there in the cardiothoracic space. There is a few other pockets of studies, small, so I would not say enough to support a systematic literature review or meta-analysis, but there are pockets in the critical care space, the cardiovascular space, so cardiac surgery, neurological care, strokes. What you're seeing as a central theme is a rather homogeneous patient population. So you're not dealing with a lot of heterogeneity of criticality or condition. Adaptable acuity that has the ability to take a decompensated orthopedic surgery patient from floor to ICU, which is not common, and then also blend it with a pneumonia patient that gets admitted to the floor, that flexes up, that requires ICU care. Those are areas where I would say are a bridge that's relatively far to cross in the short term. I'd say much more in terms of the homogeneity. So acute respiratory illness makes sense. This is just an opinion. Acute stroke makes a lot of sense. And then clearly cardiothoracic surgery makes a lot of sense because they're already doing that in various instances. And Professor Cecconi, please feel free to chime in if you have anything else to add.
Yeah, thanks, Bob. Yes, I think those are probably good examples, but I would say I work in different parts of the world, and I connect very often with clinicians working in different parts of the world. So I think it also depends on your environment, your organization, and your resources. Probably the common trigger to think where you could pilot it or this concept is exactly what you were saying. There are moments where you move from an intensive care bed either to an intermediate care bed, and then again you go to the ward. Sometimes maybe it may be perceived that the jump is too big. If you think about craniectomies or cardiac surgery patients, they are known to have very low mortality. They come to the intensive care, however, and I think that's the appropriate way to do it. They wake up in the intensive care, and often the day after they may be sent to the ward. So to think about a more continuous transition of monitoring and to be able to spot deterioration of the patient makes a lot of sense. But I wouldn't rule out to do this in other situations a bit more heterogeneous, like for instance, respiratory illness. And you can think about the flow, not just from the intensive care to the wards, but also to the in the other way. Think about entrance from the emergency department, but the patient that maybe is not sick enough to come to the intensive care. And again, this depends very much on where you work and which resources you have. Intensive care capacity around the world is very variable. You go to anything from 4.5 ICU beds every 1,000, every 100,000 population to 27. So, you can understand that while everyone knows that a ventilated patient will go to an intensive care unit, the intermediate level, the level 2 and everything else is actually very variable. So I would say probably a good way to start is to think where you think that in your hospital there is a gap between a high intensity and then to the next step, or from where a patient that does not require yet intensive care in your environment, but you would think that maybe would benefit from extended monitoring and the ability to spot deteriorations to scale up treatments and so on.
Yeah, and Joan, if I can just follow on to that, because Professor Cecconi makes a really great point. Just to restate, most of the experience to date that's published is taking a patient that comes from a critical care level, and then they're going to de-escalate as they progress. What has been less published but intuitive is being able to do it from a low acuity to be able to flex up to high acuity. I'll just give you a personal example because I was part of this, is that in the emergency medicine, we expanded this concept of observation medicine. Clinical decision units where started at 6 beds, went up to 30 beds, where you are in a transition. Are they sick enough to stay in the hospital? Are they not sick enough to go home? That kind of served as the foundational element where you can take a patient with a suspected acute myocardial infarction or COPD that requires nebulizers every 2 hours and see if they progress one way or the other. That concept already started, has demonstrated success, and the opportunity now is to be able to expand that within the hospital environment so that you can actually provide continuity within a bed as opposed to just an emergency department.
Yeah, it's interesting to think of it, as you said, we talk about de-escalation, but that area of escalation also might play a role.
Exactly.
There's a couple of questions here that are similar, and I'm going to try to group two of these together here. But one of them is about examples of places that are doing this well already, and that goes with another question here, which asks about adoption of adaptable acuity in developing countries. Are there examples of that, or are there infrastructure that prohibits adaptable acuity in places that are still developing their healthcare systems?
I defer to Professor Cecconi first because he's witnessed it and he's lived it.
So it's a great question, and again, it goes back to what we were saying before. I don't think one size fits all here. It's also like telemedicine was started basically in the US. We are learning that we can use it also in Europe now. But when you go down to a low middle income countries, sometimes the problem is that simply, you don't have enough resources. And there is a trade-off between understanding how this concept is helping you, or where actually you should stop because it's diluting too much the expertise and the nurses and the doctors that you have available. What you don't want is not to have enough staff to take care of a normal ICU and then just sending the staff around the hospital where you don't cohort patients. So the trade-off, I think, is that. Saying that, I do believe that actually having extra monitoring, and this is something that is becoming more and more popular and more present even in low and middle income countries, can allow even limited number of clinicians to spot the deterioration and to act more quickly. So one thing is to understand where you can provide organ support, and maybe you don't want to do that in every bed that you have if you don't have a system to be able to have the skills for the healthcare workers to take good care of patients outside of an ICU environment. But you can still think about having maybe extended monitoring in more beds, exactly to help the fact that you don't have enough people. And so to embrace this with early warning scores, and the ability to really to flag when a patient is deteriorating so that the ICU team can go and interact very quickly. When we speak about low and middle income countries, one of the things that I've learned, however, in the last few years, it's one term, but actually it takes into account very, very different situations. I've recently been doing some educational work with Africa, and what you really need in Africa now is not just technology, but is actually to teach people how they can start to build their intensive care unit. And one of the most successful way we've seen it was actually not through fancy devices, but actually was through a lot of teaching that was delivered locally, and so that you could really scale up and increase capacity by increasing the skill of as many healthcare workers as possible.
John, if I could...
Go ahead.
No, go ahead. I'll follow on afterwards.
Okay. I was going to take a slightly different direction here. Hopefully it still fits in. Talking about limited resources and resource limited settings in low income countries, however we choose to define that, we talk a lot about technology being a force multiplier or a healthcare worker extender. We're talking about how in those areas where we may not have the resources for nursing or different just supportive staff in general, or oftentimes physicians, how we use technology to expand that. And I guess I'm thinking, are you guys seeing other areas of technology that are supporting these adaptable acuity models? Are you seeing other ways in which we can take those resource limited settings, whether it be in Italy, whether it be in Africa, the US? Are there other technologies that are playing into this way to expand the ability of limited resources, human resources, to take care of more patients?
Yeah, if I can take that one first, because it kind of follows on with the commentary I had to follow from Professor Cecconi. Sure, I mean, resources in general is an aggregate term, but resources means headcount, bodies. There's an education and there's a physical nature to it, but then there's also technology as a resource, whether that's a mechanical ventilator, an endotracheal tube, or other novel technology, if that's an algorithm or the like. So, part of it is, as Professor Cecconi was perfectly commenting, resources, education of resources is one element, right? To be able to go and train up staff, to be able to go and manage a patient with a mechanical ventilator, as an example, right? That's a particular skill set that can be trained not only in the United States, and I take a U.S.-centric lens, but I've been around most of Southeast Asia, and those capabilities can be trained to the more rural environments. However, technology, right, as a resource, now there are other capabilities. Early warning scores is an example, but as we will progress, if you go into machine learning, there will be machine learning tools that will be able to help risk stratify patient populations, to be able to identify which ones are at a higher probability of requiring an escalation or a de-escalation of care, so that you can prioritize your resources there, while you can put the others into a different stream of a care pathway. And then lastly, in terms of a technology standpoint, wearables. As Professor Cecconi showed, I'm quite familiar with the ultrasound world. I started an ultrasound elective program in my emergency department 15 to 20 years ago, and we wheeled around ultrasounds. Those are bygone eras almost. I mean, you literally have digital visualization of the aorta, of the right upper quadrant, DVTs, etc., that can be done on your smartphone. So that same technology now, in terms of wearables for patient monitoring, right? Whether that's vital signs, right? To be able to identify if respiratory rate changes, or to be able to see if fever develops, as opposed to that spot check every 2, 4, 6, 8 hours. You now have more continuous data streams. The one word of caution that also Professor Cecconi talked about is being inundated with too much data that paralyzes you to be able to take care of the patient. So it's a balancing act. So I think it's not just one targeted approach. It's a layered approach of resources, personnel resources, well-being of those resources, and then looking at technology enablers that can help streamline those resources. Very much in a multi-dimensional symphony relationship.
I completely second that. I completely agree, Bob. And I think, to be honest, this is what we hope, and I believe also what we need to demand to to companies like yours also to work not just for the high intensity and availability of resources, but also where there are less resources, to understand if the algorithms can be adapted there. What you want is to have a technology that allows you to spot the difference between the noise and the signal. So I don't want to waste my time looking at 50 screens that are just adding my workload. I want to be able to look at the screen that is important in that moment. And for years we talked a lot about phenotypes in terms of genetics and so on. Now we start to understand that probably is much more feasible, and it is what we have. So this is what we just have to do with these physiological phenotypes. So how is the patient that is in front of me similar to another one that maybe I've seen or somebody else is seeing? And so how can we spot that deterioration, understand how to treat it very early, and also avoid false alarms? We really need to have systems that are sensitive, but also specifics. I worked in different parts of the world, and what I've seen about early warning scores, they work very well if when a nurse is a patient that is deteriorating and flags red, calls the doctor, and then the doctor is helping. However, if you have 20 false alarms, at some point people get tired, they get fatigued, they don't want to use that. So when we talk about adaptable acuity, it goes hand in hand with having smart systems, smart algorithms that will be able to characterize phenotypes. Okay, it's better to have one extra call, but we don't want to have too many false calls. You want really to be able to spot who needs care in that moment early, and that can help to reduce the bureaucratic burden and the digital burden that we have now as healthcare workers. We spend far too much time writing notes on the chart and not enough time with patients.
I like the idea of fitting these technologies into existing systems already. You talked about handheld ultrasound, for example. When I was in East Africa 20 years ago, there were flip phones only, and those were not prevalent. But now the ability really to have a handheld device in almost anyone's hand and fit that into how we are expanding getting those signals and hopefully reducing noise. Again, I think it's the big challenge, as you've mentioned, is we can sometimes have too much data. So how are we really using what's there already, but also using it in an efficient way? That is a challenge. One last question for you both. It's come up in the chat as well. Great examples of places who are doing this well. Can you think of places as people depart this conversation? Are there places they should look to as examples that are doing this effectively?
Professor Cecconi, you want to start?
Well, I don't like to speak about other people, so I will speak about myself. And I work in a hospital in Italy, which is probably one of the most digitalized and monitored one. I can tell you that I don't have the number of ICU beds that I would like to have, because ideally I would just like to have more and more, but it was simply not feasible to increase at the pace that I wanted when I started here 6 years ago. But we do have a lot of monitor beds in other parts of the hospital, and we use this concept of sending patients from the ICU to wards where we can actually spot the deterioration, then intervene, maybe help the team there to deliver care or deliver support that is there, where there is some minimal invasive respiratory support and so on. I don't know if this is one of the reasons, but our hospitals for the last few years has been topping the benchmark for the benchmark of our hospitals in Italy. And recently, you may have seen yesterday, Newsweek has published the best hospitals in the world. We are in that ranking. We are not the only one. There are many, but I suggest that could probably be a good list to start to look at what people do. And To me, this is a philosophy. It's a philosophy about ownership of the critically ill patients also outside of the ICU. So it's not about leaving that patient and leaving that care just because the patient is not anymore in the ICU. And at the same time, thinking that a potential ICU patient, a potential sick patient in the other part of the hospital is still your ownership. This is the way I see it. And this is the way we're trying to organize our care and to try to organize how we create a digital safety network and importantly, a clinical safety network for our patients. But I'm sure that Bob has better example than mine.
Yeah, thanks. Yeah, there's a couple, you know, to me, I'll just follow on one concept that was mentioned is facilities that are willing to be innovative. And I think that's the starting off point. There are, at least from a US-centric lens, it is looking at facilities that are willing to go and pilot in innovations. And there's a couple that jump to mind. Intermountain Health is very well known in the United States for being much more progressive in exploring novel care deliveries. The other one is down in Louisiana, Ochsner Health. But really more, for me, practically speaking, I've witnessed this and I've interacted with them, is out in Wisconsin, which is Aurora Healthcare. They have a network of over 20 hospitals, and they have novel care deliveries for their what is considered sort of intermediate care, someone that warrants being admitted to the hospital, but typically in a hospital, on a hospital bed, they require Q4 hour or every 4 hour vital signs max. This is a place where Q2 hour vital signs would occur, which is more step down, but they're still on the floor. And they're taking a lot more of the acute cardiorespiratory care as well as stroke care that may have otherwise been placed in an ICU in another environment. That is a place that requires a commitment to innovation and a commitment to training the resources and being able to go and provide the staff support to be able to care for I'd say a low acuity ICU patient on the medical floor. So I would say that has been examples of transformative care. I'm sure there's others ex-US. I haven't had much experience of late. I would just say one of the poster child examples of where adaptable acuity would be germane is in Australia. You have somewhere between 500 to 1,000 kilometers that may separate an acute care environment and an intensive care bed. How do you manage that resource where they do not need to be put onto a fixed wing aircraft and flown for 2, 3, 4 hours at exorbitant expense while being able to not diminish care delivery in Western Australia? That would be a phenomenal poster child where resources aren't constrained per se, you are just physically constrained by distance.
Yeah, excellent examples. Certainly not an exhaustive list, but I think a great shout out to places that are doing it well and places that are really seeing different challenges and using this way to address them. We are at our time right now. I really appreciate your comments. I appreciate the questions from the audience. Thank you for attending this webinar. For those of you who are in attendance, as you guys are departing, we'd appreciate your feedback. There is a quick 5-question survey that will appear as you close the broadcast. It should take you no longer than 5 minutes to complete. With that, I appreciate our presenters. Thank you, gentlemen. Thank you for our attendees. Thank you all for coming. Please stay well.
Thank you, everyone. Thanks for listening.